For this week, the focus of the pharmacology videos will be on pain and inflammation. Now, in the case this week, you will see several agents that should look familiar to you because we have addressed these pretty in-depth in pharmacology videos from other blocks. So, for example, hydrocodone was covered in the pain and opioids video in block 4. So I will not spend time in this video reviewing opioids, but you should be familiar with these for your IQ discussion, and if you would like a refresher, I have included a copy of the note from block 4 in the box folder for this week. Also, alendronate, which is a bisphosphonate, is included in the case this week and is treating the underlying cause for this patient's pain. And we went over bisphosphonates in a similar context, but for osteogenesis imperfecta in block 3. So I will also not review bisphosphonates in this video, but again, be familiar with this class of agents, and a copy of the block 3 note is included in the box folder if you need to review this class. So if we're not going to be discussing bisphosphonates or opioids in this video, what are we going to be talking about in terms of pain and inflammation treatments? And the answer is our non-steroidal anti-inflammatory drugs, or NSAIDs. So we've talked about NSAIDs before in previous videos, so a lot of our discussion today will be brief and it will be a review, but we really haven't talked about NSAIDs in the direct context of pain and inflammation treatment. So if you recall, we talked about NSAID-induced peptic ulcer disease in block 3. We talked about NSAID drug interactions with ACE inhibitors and ARBs in block 4, and we talked about the use of low-dose aspirin, which is a non-steroidal anti-inflammatory drug for antiplatelet effects in block 4. So my hope is that this video will provide a nice review of this class of agents in one centralized resource. So NSAIDs are widely used and available both over the counter or OTC and as prescriptions in a variety of formulations, including oral, IV, topical, and so on. And these are used to treat pain associated with a variety of causes. And pain can be classified in many different ways. So we can have acute or chronic pain. We can have visceral, somatic, or neuropathic pain, and we can have pain that is ranked by severity. And the classification of the patient's pain can help determine if an NSAID is going to be a good option and may help determine which NSAID to use and at what dose. So these nonsteroidal anti-inflammatory drugs include things like acetaminophen, which you've heard a lot before in block 4, ibuprofen, naproxen, ketorolac, aspirin, and others. So for instance, if we rate the patient's pain based on severity, for mild pain patients, we can probably start off with acetaminophen or ibuprofen, potentially even at over-the-counter doses. Other NSAIDs, or the same ones at higher doses, may then be applicable for someone with moderate pain. But once we start to hit this moderate level of pain or moderate to severe pain, the NSAIDs may not be sufficient on their own. So just keep in mind that usually NSAIDs are more for that mild to moderate pain severity. So now, how do the NSAIDs work to target this mild to moderate pain and inflammation? And we first need to review the arachidonic acid pathway, prostaglandins, and thromboxanes first. So the arachidonic acid pathway is important for the synthesis of eicosanoids, which are potent inflammomodulators. And these include our prostaglandins, which I'll abbreviate as PGs, and our thromboxanes, which will be TXs, and as well as our leukotrienes, but we're not going to focus as much on the leukotrienes in this video. So these substances also play an important role in promoting homeostasis separate from inflammatory processes. So this pathway begins with our membrane phospholipids, which are converted to arachidonic acid by phospholipases like phospholipase A2. Arachidonic acid is then converted to PGG2 and then to PGH2 by cyclooxygenase enzymes like COX-1 and COX-2, and then this goes on to become thromboxane A2, PGE2, PGI2, and others. Now, COX-1 enzymes are constitutively expressed in the platelets, the GI mucosal cells, renal tubular cells, as well as in other components of the vasculature. And the production of prostaglandins and downstream thromboxanes through this arm is what helps to maintain homeostasis. For For example, thromboxane A2 that's generated by the platelets will bind to its thromboxane A2 receptor to enhance platelet aggregation, and PGI2 or prostacyclin, which is generated by nearby epithelial cells, will actually bind to platelets and inhibit platelet aggregation. So this provides a balance in platelet aggregation. The production of prostaglandins like PGE2 and binding to its respective receptor in the GI tract leads to a slew of cytoprotective effects, like a reduction in gastric acid secretion in the stomach and an increase in the production of mucus and bicarb in the stomach and the duodenum, to provide some protection to the GI mucosal cells. And then the last example I will provide is the production of vasodilatory prostaglandins like PGI2 or prostacyclin in the kidneys. And this will control the vasodilation of that afferent arteriole and the blood delivery to the glomerulus and help in the regulation of renal blood flow. Now, COX-2 enzyme expression, on the other hand, is inducible at sites of inflammation, and its expression is upregulated by things like cytokines, shear stress, and growth factors. This surge of pro-inflammatory prostaglandins and thromboxanes from this upregulation of COX-2 enzymes leads to increased vascular permeability, leading to that inflammation and edema. There is also going to be increased platelet leukocyte interactions. There's going to be increased pyrogens, which can lead to fever. And there's going to be increased propagation of pain signals due to reduced threshold for nociceptor stimulation. So we're also going to get pain. So these COX-2 mediated effects lead to pain and inflammation and is going to be our primary target for our nonsteroidal anti-inflammatory drugs. So hopefully you remember that NSAIDs work by inhibiting COX enzymes to prevent this generation of pro-inflammatory mediators to prevent this pain and inflammation. However, not all NSAIDs are created equal and have different levels of selectivity. So in this video, we will specifically go over our non-selective NSAIDs, our COX-2 selective NSAIDs, and acetaminophen, which I will abbreviate as APAP. So starting off with our non-selective NSAIDs. And this will include agents like our high-dose or normal-dose aspirin, which we won't talk about low-dose aspirin today. We'll also include our ibuprofen, our naproxen, and many others. And these agents are going to inhibit COX-2 enzymes, which remember is our primary target. But also, unfortunately, these agents are also going to inhibit our COX-1 constitutively expressed enzymes as well. And this is going to lead to imbalances in all of these homeostatic processes, as well as other homeostatic processes that are not included on this slide. And that is why NSAIDs that are non-selective come with a number of serious concerns like GI ulcers, increased bleeding, but also thrombotic risk, because remember, prostacyclin and thromboxane sort of balance this platelet aggregation. There's also going to be an increased salt and water retention, edema, potentially reduced renal function, and cardiovascular events. These reasons are why there are daily dose limits on NSAIDs, why certain strengths are only available by prescription, and why it is important to ask a patient about their over-the-counter medication use and counsel appropriately, because several NSAIDs are available over the counter, which gives the illusions that they come without risks to the patient. In addition to the concerns that I've outlined on this slide, some of the major dose-limiting side effects are GI pain, nausea, and diarrhea, and most NSAIDs do require hepatic metabolism and renal excretion, so hepatic and renal dosing adjustments may be needed for these agents. Also, these are extensively protein bound, So this means that there can be drug interactions with other highly protein-bound drugs, especially those bound to albumin, and in cases of overdose, hemodialysis will not be helpful because of this high degree of protein binding, except for with aspirin. So now our COX-2 selective agents like celecoxib are going to have greater selectivity for that COX-2 enzyme inhibition, which again is our primary target in the case of pain and inflammation. So the idea was that all of these homeostatic processes that were altered by our non-selective NSAIDs would be less concerning with these COX-2 selective agents, which is true at least in part because the risk of GI ulcers and the risk of bleeding is reduced with our COX-2 selective agents. But the cardiovascular related risks are higher because of a presumed reduction in prostacyclin, which is usually our vasodilatory prostaglandin and our inhibitor of platelet aggregation. So less GI concerns, but more cardiovascular concerns. So the selection of these agents is going to depend upon a lot of patient factors. And similar to some of the concerns with the non-selective NSAIDs, we are still going to be worried about highly protein-bound drugs and drug interactions, as well as patients with hepatic and renal impairment that may need dosing adjustments. Now, the last agent we will briefly discuss is acetaminophen, or APAP, which typically gets lumped in with the NSAIDs, even though its mechanism of action is somewhat unknown, but definitely thought to be different than all the other NSAIDs we discussed. So this agent actually has really weak anti-inflammatory effects, but it is good antipyretic and analgesic effects because it's thought to actually work centrally, potentially through inhibition of COX enzymes, and this leads to an inhibition of endogenous pyrogens and an elevation in the pain threshold. So because it works differently, the side effect profile is very different and is used for some different indications, since it won't do too much for inflammation. And I won't harp on this because we've discussed it a lot in Block 4, but hepatotoxicity is one of the greatest concerns with this agent, so counseling on its safe use is important because it is also available over the counter. So moving to our summary slide. So I hope this video has provided a good review of the NSAIDs class and brought together some of the key pharmacologic considerations relevant to the other blocks, together with a more in-depth understanding of the NSAIDs mechanism of action and side effect profiles. So by gaining a better understanding of the nuances of this widely used class of agents, this will help you better understand the patient factors that must be considered prior to agent selection and how to educate the patient on the safe use and appropriate expectations related to NSAIDs for the treatment of pain and inflammation.